That's me. Okay, so today I'm going to be talking to you about fetal MRI, and I'm going to be talking to you about the techniques involved, and this is hopefully going to follow on really nicely with Dr. Fink's talk straight after, who's going to show you some nice examples and show when and where fetal MRI is actually useful and where it makes a difference in what we do. So this is just the number of the referrals here in Melbourne over the last 12 years. Fetal MRI has been around since about the 1980s, but it wasn't until about the 1990s when the fast imaging techniques or fast imaging sequences came along that it really started to show some promise. And if you look here, you can see the last 5 years, there's just been a really steady increase in the number of fetal MRIs we've been performing. Now this number could actually be far more than this, but we're limited in the amount of scan time we can have. Obviously in Australia you can't get a rebate for fetal MRI, so that limits the scan time we have. As all of us, there's always pressure on your scan time. If you look worldwide, they're going to show similar patterns as well. Last 5 years there's been a really big increase in the number of fetal MRIs being performed. And if you look at publications as well, it's a similar kind of scenario. And if you look at the cohort sizes in those publications, again, very similar. So a lot more fetal MRI going on, and that's adding weight to the potential use of this technique. So I'll just break up my talk for you. You're going to start off with preparation for the mum, etc. Imaging and the sequences we use, how we modify those sequences for fetal MRI. Some of the challenges that are involved and how we overcome them. We don't always overcome them. And the safety considerations is quite important if you're considering setting up a fetal MRI service. There are some safety considerations you need to think about. And lastly, the future role, where we think fetal MRI is headed. There's obviously a lot of research going on at the moment as well as clinical work. So we'll start off with a referral. Our referral usually happens in the second trimester after an abnormal ultrasound. It can be third trimester as well, but second trimester is the most common. We don't scan in the first trimester, and this is really a precaution against any unknown effects. Obviously the major organogenesis is occurring in the first trimester, so guidelines state we should be avoiding scanning, even though we don't think there are any adverse effects. It's also quite hard to scan in first trimester. The fetus is very small and very mobile. It's hard to get any decent imaging. We like to have that recent ultrasound there, know exactly the area of interest we're looking at. We do go on to image the whole of the fetus, but obviously you want to know the area that you're concentrating on at the start of the examination. We also like to have a radiologist present. That's because fetal MRI is quite a dynamic scanning process. The scans are very fast, obviously. You're constantly planning your next sequence, and you don't actually have a lot of time to stop and look at your images and assess the pathologies. So quite often you're going to find a pathology that we didn't know was there. I think in about 20% of cases there's extra pathology discovered, and it's quite good to have the radiologist there, can spot those pathologies and then modify your technique and the protocol that you're actually using dependent on those findings. So next, patient preparation. Informed consent. The patient will have been consented by their obstetrician or referring doctor and should know exactly why they're coming along for the MRI. Now, in Melbourne we don't fast our patients, but lots of centres will fast their patients. They'll either do an overnight fast and scan them first thing in the morning, or a 4-hour fast. And this is because there's some evidence that hypoglycemia will actually lower the fetal motion, and that fetal motion is a bit of a problem, which we'll come to a bit later. You might also ask them to avoid caffeine or fizzy drinks. That again might lower that fetal motion that occurs. Some centres as well ask mother when they think the fetus is less active. There might be certain times of the day that you think the fetus is less active. We don't employ any of these techniques only because our referral system is very rapid. We're usually scanning the patient only the day after their abnormal ultrasound, so it's always quite hard to fit them in. Now, reassurance, this is quite an important one. As I said, they've had an abnormal ultrasound maybe even the day before or a few days before, so very, very anxious. They've just discovered that their unborn child has an abnormality. They know it's very unusual to come for an MRI scan, so they might have some safety concerns. And you've really got to spend quite a bit of time talking to them before you go into the room and trying to relieve those anxieties. It's obviously not always possible because they're very concerned about the results. The results might be altering the management of their child. It might be that they're considering a termination. Quite often that's the example. So as I said, really spend quite a bit of time, and it's not because we're nice people that we do that. It's just because the less anxious mum is, the longer that she might lie on that table for you, and the less fetal movement as well that might occur. Now we also get them to bring a partner along just for support, and we'll let the partner into the scan room with them as well for support. We don't use sedation, and not many centres will use sedation anymore. Those ultra-fast imaging sequences mean it's not really necessary like it was in the old days. Now, patient position, we like to use feet first supine, feet first for the mother, and supine for us, because that's quite easy for us to have the coils placed in the supine position. Unfortunately, mum can't always manage this position, and that's because of, especially in the later gestation or multiple pregnancies, there's going to be compression on the inferior vena cava and the aorta, as you can see here, and this is going to make mum quite dizzy and nauseous and sick. So sometimes it's not possible to scan in that supine position. If you turn mum onto her left side, those compression symptoms are immediately relieved, so sometimes it's necessary to scan in the left lateral position. We like to just scan somewhere in between, so we'll just maybe lift the right side 10 or 15 degrees. We feel we can get better coil placement like this than with the mother completely on her side laterally, but anywhere in between is quite good. So back to the magnets and coils. Now, fetal MRI has been performed at 1.5 Tesla and 3 Tesla. I'll go into the 3 Tesla a little bit more towards the end of the scan, but it's definitely been produced on both scanners at the moment. Coils, combination of coils. Some centres are using the small cardiac coil, and other centres using 32-channel cardiac coils. That's what we used to be using, or body arrays combined with your spinal elements. Now, at the moment, we're using a 1.5 Tesla Siemens Air scanner, so that's got that really nice wide bore, so that's quite nice for mum. And it also has a really large body coil. The body matrix is a lot bigger than this. It's got 18 channels, so it gives us a lot more coverage, and we find we don't have to move the coils around a bit like we used to. So if you're using this sort of smaller cardiac coil, you might need to move that during the examination, so we'll just talk a little bit like that. It's really important, the coil, as I said, not a problem for us nowadays. We don't find we have to move the coil at all, but if you're using a smaller coil, you really need the coil central to the region of interest. So if you're looking at the fetal head, for example, you need to make sure the coil is central to the region of interest. So on your first image, assess where your signal drop-off is, and then if you need to, go in and move that coil. And that's going to mean if you're using a smaller coil, you're going to need to move it during the examination to look at the fetal body if you need to do that as well. But it's quite important. It makes a big difference in some of your sequences, especially diffusion. Diffusion suffers a lot if you're requiring it at the periphery of the coil. So we'll look at the imaging sequences themselves. So obviously we start off with a Scout, which is a multiplanar stack. You can do it in HASTE, TrueFace or T1. We're using TrueFace at the minute. And here, this is the first sequence planned orthogonal to the maternal pelvis, and it's the only sequence that's planned to the mother. From now on, we're going to use the fetus, obviously, as our point of reference. And every sequence you do from now on will be your plan for the next sequence. And that's how fetal MRI works. You're always using your last sequence to plan your next one. And that's because the fetus has potentially moved, obviously, since the start of the examination. So your Scout has a large field of view, it incorporates the whole of the uterus. It's going to give us a nice overview and orientation. And it's going to tell the radiologist basically which side is which, and that'll be important if there's any pathology present, obviously. So as I said, the next sequence we'll look at is the T2. Now, this is the workhorse for fetal MRI imaging. It really gives us great soft tissue contrast, and you can get some really nice imaging. So this is what we'll start off with, T2 imaging. We're using a HASTE. We also use TrueFace as well. We'll talk about that in a minute. A single shot, so it can be acquired in less than a second, so it's ideal for fetal imaging. If you're looking at the fetal head, which is the majority of work we do, you need to acquire your slices in the 3 orthogonal planes, and those planes need to be quite perfect. You need to spend a lot of work making sure that they're very correct, because any slight loss of plane, you're going to lose your diagnostic appeal of those pictures. Now, one thing we will change a little bit is our TE, and that's going to depend on the part of the body we're looking at and also the gestational age. So we'll fiddle a bit with the TE and our T2 hastes. So in the T2 body, for example, a TE of about 90 is going to give us the best organ detail. But then if you move to the fetal head, things are a little bit different. There's obviously a lot more fluid in the fetal immature brain and a lot less myelination as compared to a term infant, for example. So we have to use a TE of about 140 to get really good grey-white matter differentiation. As the gestation gets older, obviously that water content reduces slightly. There's a bit more myelination going on. So sort of from 32, 33 weeks onwards, we might bring that TE back a little bit to about 100. And that still gives us the good contrast we're looking for, but it's going to shorten the shot time ever so slightly for us. So the next T2 sequence is the TrueFace. As I said, we use a combination of the two because they do depict things slightly differently, even though they're both T2 weighted. Looking at these examples here, there's obviously a slight chemical shift artifact on the subcutaneous fat of the baby. So it's really nice for looking at the profile of the fetus here in this picture. So you get a really nice profile of the nose and the chin and the mouth. So that can be quite nice if you're looking at facial abnormalities. Also in this other example here, really nice demonstration of this meningocele, really showing the skin surface over the top there, which is obviously very important in the diagnosis. Obviously the other major difference between the two sequences is how they depict moving blood in the heart and the great vessels. So on your TrueFace picture, first thing you're going to see is that signal void from the beating heart, and that's the first thing we look for when we take our T2 image to make sure that heart is beating. And the TrueFace picture, it's obviously going to be a bright homogeneous signal in the heart chambers and great vessels, and this has been utilised for cardiac fetal imaging, which is a lot of research going on with that at the minute. Next T2 sequence is the fetography, they call it, but it's really, as the last speaker was talking about, it's basically a thick slab MRPC type sequence. It's heavily T2 weighted, and basically it's quite quick to acquire, 1 or 2 seconds, and it's going to give us a nice overview of the fetus, or very, very quickly. You can alter the thickness depending on the gestational age, but about 20 to 50 millimeters is what we're using. And gives us a nice global overview, and it's going to show you proportions of the baby, unlike ultrasound, which can't show you the whole fetus in one go at the later gestations. This image is going to be great for showing the whole image fetus at once and giving you a nice 3D perspective. So if you look at the picture in the middle here, there's a large lymphatic malformation there. So these pictures were nice, and we acquired this in a 3D radial stack, and it gave the surgeons a good look at just how extensive it was in proportion to the baby itself. So next we'll go on to the T1 sequences. Now these take a little bit longer to acquire, so you definitely need to have a maternal breath hold here, and they're obviously going to be more prone to fetal motion. They take about 15 to 30 seconds to acquire depending on what we're using, and we're playing with different T1 sequences at the minute. T1 in the head isn't actually so helpful, and again that's because of that high water content and reduced myelination. There's not actually much contrast there. We do, however, still run it because it's going to show us any blood or blood products or fat that's present, so we do still run it in the head. It starts to become much more useful in the fetal body, and that's because the meconium in the fetal bowel shows up as very bright on T1 imaging. So you can see there the example on the left. The meconium in the bowel, this is a patient with a diaphragmatic hernia obviously, and the bowel up here in the chest, and that's really nicely demonstrated by that meconium that's present. Also you can see the thyroid is bright, and that's normal, so if there's any thyroid issues you can use T1 imaging to look at the thyroid as well. And I think in Michelle's talk you'll see a few examples of where the T1 imaging is helpful. Again, you can acquire this in a 3D radial stack type protocol and get sort of virtual colonoscopy. EPI and diffusion. Now, we run EPI on all of our fetuses as well. It's very quick to acquire, obviously. It takes about 4 seconds to acquire the whole head, and it's very, very sensitive to hemorrhage, and that's why we use it. And just an example here of it showing some hemorrhage here. There's the fetal imaging, EPI imaging, and then the postnatal SWE imaging alongside, and both demonstrating these areas of blood products quite nicely, obviously. So very, very sensitive to hemorrhage and very quick, so not prone to fetal motion. EPI has also been used by some institutes to look at skeletal development. As you can see on this EPI picture here, the ossifying bone is hypointense, and the cartilaginous epiphyses are hyper-intense. So there's a little bit of research here going on at whether we could look at skeletal development using this EPI sequence. Diffusion. Now obviously diffusion has great potential if you can acquire it. It's going to really show us any potential hypoxic ischemic events. Again, like the T1, it's longer to acquire it, and it's very noisy. It's going to take about 20 to 30 seconds. So again, more prone to movement. But if you do get it, it can be very, very helpful, obviously. It can be helpful in the body as well, and especially if you're looking at the renal tissue. Renal tissue is going to show up as really bright on your body diffusion. So it can be quite helpful if you're, say, looking for an absent kidney or ectopic kidney tissue. Body diffusion is going to help us locate that, so it can be quite helpful there. We've just introduced that into our protocol. Now next is the TrueFace cine, and this is just used to be a little pretty picture to show mum and show that the heart was beating, but there is actually quite a lot we can get from these images, and there's a lot of research going into how we can use the TrueFace to gain more. So originally we just used to look at it to look for swallowing. If you say there was esophageal atresia, you do a very thin slab and look at this, wait for the fetus to swallow. But you can use it for lots of other things. It's obviously been used for fetal cardiac assessment, even though that's quite difficult because it's such a small structure. But definitely work going in there to acquire all the fetal planes, 2-chamber, 4-chamber, etc., using TrueFace cine. They're also trying to use it if they look at sort of bulk motion, abnormal motion, and trying to link that to neurological disorders and see if that can be a help in ascertaining which neurological disorder is present. So, okay, we'll come to the challenges now. The biggest challenge is fetal motion. Every fetal examination you perform, you're going to be repeating some of your slices or some of your sequences because of fetal motion. It's always going to happen. And I'll just show you this one. Babies usually have a period of fetal motion, like this one, and then they'll usually stop and be quite calm for 10-15 minutes. Now this baby didn't. This baby did this for about 35-40 minutes, and even though I can smile about it now, I don't think I was smiling at the time at all. This was we gave this baby some very bad names. But what we did, so we had to stop the examination. The baby was just far too active. And what we did is got mum to come back another day, and the examination was very successful then. But that was quite unusual. As I said, the movement is usually a period of movement for a minute or so of this large movement, and then it stops and there's a quiet phase, and that's when you image as quickly as you can and try and get through the images. So what happens when you haven't got that gross movement there? If they move during the slice acquisition, so you see this picture on the left here, the fetus has obviously moved during that 1 second acquisition, and it looks a little bit like a cat in a washing machine. You can't really see anything. Big signal voids in the amniotic fluid, and obviously fetus is completely out of plane, so you need to repeat those sequences obviously. It's quite common in the head, even in the late gestations, when you think, oh, the head's down and engaged in the pelvis, there's not going to be much room for this fetus to move. There's always frequent head motion, and that's because the fetus has always got room to nod and turn its head, which it seems to constantly do. So again, you get these signal voids here, and that's just merely the fetus turning its head during that 1 second acquisition. Now I don't often relocalize if that happens, because the fetus often will return to its original position when they're just doing this head movement and it's not a big bulk motion. So you can just basically stop, maybe wait a minute or two and then start again, and hopefully the fetus will actually be in the same position. This is obviously the other common thing that happens. You plan your sequence, it looked perfectly axial, and then you start acquiring it, and the radiologist is tapping you on the back saying, it's not axial. So you need to go and obviously stop taking pictures. These are not going to be a very good diagnostic quality, and even the slightest angulation off of such a small structure, you're going to lose the plane very quickly. And obviously by going back and acquiring them in the perfect plane, they're going to give you far more diagnostic information, so you really need to make that effort to get those perfectly in plane. So the maternal breathing and movement is the other challenge. Now obviously movement, make mum as comfortable as possible at the start of the examination, and also limit it to what's called the comfort time. So there's a time period where the mothers will lie there quite happily, and after that she's going to become quite uncomfortable, and that's usually about 35 minutes, and that's when you actually need to stop, when mum starts moving around. The other problem is obviously mother breathing, and it depends on the fetal position and what we're looking at, how much of a problem that is for us. So if you look at this example here, if we're looking at the fetal head again, for example, the fetal head is down, engaged in the pelvis here. Maternal breathing isn't going to cause us much of a problem. And I'm not going to bother to breath hold my T2 sequences because it's quite tiring for mum to breath hold. So I'm only going to breath hold my T1 and diffusion sequences and give her a rest at all those other times. In the breech position though, with the head under the diaphragm, things are going to be a little bit different, and you might need to consider your breath holding technique a bit more. Sorry, this isn't a very good example because the fetus is moving as well. But as you can see here, as the mother breathes, just how much the fetal head is moving up and down. And if you're looking at 3 or 4 millimeter slices, which is what we're requiring, you're potentially going to miss quite a lot of information unless you use breath hold techniques. So we'll use an interleaved concatenated scan to acquire and use breath holds of 5 or 10 seconds, even for our T2 imaging in cases like this when we're looking at the fetal head. Wrap, this is always really embarrassing when this happens, so try and avoid it. Obviously you want a small field of view, but you're going to get the maternal frame wrapping in if you're not careful. So obviously you've got to use oversampling, no phase wrap techniques. Also keep an eye on your phase direction. It's going to flip around a bit because you're going to be using very odd angulations, and you might need to change that phase direction to avoid the wrap. So again, it's embarrassing when it happens, so try and avoid that. Last challenge we'll come to is just multiple pregnancies. Obviously we're usually dealing with twins rather than triplets, but twins are a challenge as well. One, because mum probably not as comfortable. She's probably not going to want to lie there as long. 2, we're usually having to image both of the fetuses, so you've got less time and you need to image very, very quickly to get the information you need. You also need to be careful that you're imaging the right fetus and that you're labelling the correct fetus as well. So again, having a radiologist present at those times is quite nice. And the other problem is the fetal motion. You quite often find with the twins, I think they just sort of maybe when they do move, one just kicks the other one in the head and that starts that one moving. So the movement seems to be transferred from one fetus to the other quite often, which can be tricky. So safety issues. So mother safety. We've talked about the position, and that's an important one, obviously. And I'll just talk about the other issues that aren't specific to fetal MRI. But obviously, if she's on her side, we want to make sure that none of her abdomen or arms are touching the bore of the magnet. We don't want any burns, obviously. So all those usual things we do are put in foam pads in as well. I'll also note that if you're letting a partner in and you're not used to maybe letting someone else into the scanner, that you haven't changed into a gown, etc., just be really careful. The partner is going to be very, very anxious, and just double check that they've taken all projectiles out of their pockets, because sometimes they really are not quite with it at this time of stress and anxiety. Now the static field, I don't need to talk about this too much. The clinical field strengths we're using at the minute, 1.5 and 3T, they don't think there's any problem with the static field there. They think you can go up to about 16 Tesla before there's going to be any effect on the fetus, so we're quite safe at the moment. Now gradient switching, obviously rapid gradient switching can cause us problems like peripheral nerve stimulation. That's something we don't want to do to the fetus. But luckily physics shows us that it's not really a problem. The position of the fetus within the fetal abdomen is going to mean it's protected from the major flux changes which happen on the surface of the mother's abdomen. So we don't expect that to be an issue at all. It's the next two things that are actually more of an issue, the acoustic noise and the RF heating. We really need to sort of look at these two a little bit more detail. So if you look at the acoustic noise, unfortunately this isn't an option for us. We can't do this and we can't do this either. So what are we going to do? Well, luckily again, there's a couple of things on our side. Obviously the fetus is protected by the surrounding. The maternal abdomen is going to protect it from the decibels it receives. Also its ear is going to be fluid filled. The ear will be filled with the amniotic fluid, and again that's going to reduce the decibel intensity that it receives. However, if you've got a short bore system, say, or a 3T system, you might need to be wary of just how high your decibel levels are going, and maybe incorporate whisper or soft tone or the other noise reduction techniques. You could also use acoustic foam as well. But again, maybe try and limit the amount of high decibel sequences like the EPI and diffusion that you're using. There's been a couple of studies produced that's looked at children that have undergone fetal MRI, and they haven't shown any detrimental effect to their hearing. So that's a really good sign, but there really hasn't been a big enough cohort at the minute to rule this out as a problem. Now Siren RF heating, this is the one that's causing more concern, and we need to think about this one a little bit harder. Now if you look at this is a modelling of the SAR received to a mother and fetus at 1.5 and 3 Tesla. And from this you think all looks great. The baby, the fetus, is receiving far less SAR than the mother in both cases, so everything's great, not a problem. But unfortunately it's the heating effect that's the problem. And mum has lots of good ways of losing heat that the baby doesn't have. So this is where the problems start with the SARs, is the heat that we're going to introduce. So mum can lose her heat that we are putting into her lots of ways. Obviously sweating, etc. We're also going to help her lose her heat as well, so we're going to make sure the bore ventilation's up high, we're not going to give her any blankets, we're going to make sure she's not got too many clothes on, etc. So in that way she's going to lose that heat quite nicely, and hopefully shouldn't get hot during the examination. Fetus, however, a little bit different. Mum's acting as a big tea cosy for that fetus and keeping it nice and toasty warm. It's surrounded in a bath of 37 degrees, so it can't lose heat the same way that the mum can. Most of the heat loss is actually through the placenta, but even this heat loss is compromised because in the umbilical cord the vein and the artery are actually wrapped around each other, so there's heat transfer even between the two as they enter and leave. So baby can't lose that heat, and that's the issue. We don't want to raise the temperature of the fetus by more of a degree, so we really need to watch how much SAR we're putting in, because any heat rise in the mother could be, and we don't actually know how much more, but it's going to be a lot more in the fetus. So all the guidelines state that we need to be careful about this, and basically they're all suggesting that you limit the length of the examination and that you stay at the normal level of operation, and that's again to make sure that you're not going to heat that fetus above a degree. And we don't want to do that because obviously excessive heating is a potential teratogen. So how are we going to reduce the heating effect? Well, as I said before, we can maximise the mother's heat loss. Now, that's not going to help us too much. As I said, help us a little but not a lot. But you really don't want to be getting mum hot and sweaty. If your mum starts to be hot and sweaty while you're scanning her, you need to stop scanning. The most important way you can do it is by staying at that normal controlled level of 2 watts per kilogram. Don't go into first level of 4 watts per kilogram because you're very quickly going to potentially heat that fetus up by more than a degree. Minimise the use of high SAR sequences. Now that's really quite difficult because we're using high SAR sequences in fetal MRI, HASTE and TrueFace, but high SAR. So what you can do is try and interdisperse them with the lower SAR sequences like the T1 and try and limit their use if you can, but that's quite difficult obviously. Limit the length of the examination. That's probably the second most important thing. We stop scanning at sort of 35 to 40 minutes, and if you haven't got the information you need by then, you probably still need to stop and either give mum a break or get mum back another day, because that's really, you start to be potentially crossing the level of heating the fetus up too much. This paper just came out recently from the Daniela Prayer group, and this is actually quite comforting because this, along the bottom, this is their examination time here, which is an average of 35 minutes, I think, for them. And here's the SAR that they're depositing over that 35 minutes. So this basically shows that during this examination time, they're only depositing SAR for about 30% of the time. So that's quite comforting to know that, you know, maybe the physicists are making us a little bit too scared, that we're obviously not depositing as much RF as you think, because there's lots of breaks while you're planning your next sequence and as the scanner prepares itself to do the scan. Contrast, I'm just going to quickly talk about contrast. We don't use contrast in fetal MRI. Guidelines state that we should avoid its use. And this is because we don't know what the half-life is in the fetal circulation. It is being used a little bit in placenta imaging, but again, it's not something we're considering to do. And basically what happens is obviously you administer the contrast to the mother, it crosses the placenta and appears in the fetal bladder, and that happens quite rapidly. Then the problem comes because the fetus obviously excretes that into the amniotic fluid, and then it potentially swallows it, and then it's potentially reabsorbed from the GI tract. So basically we don't know what that half-life is because it's sort of recirculating around in the fetus. So finally, fetal 3T. Now when 3T first came out, it really didn't go together with fetal imaging at all. That big bag of fluid around the fetus made image quality really poor, and it really, 3T and fetal MRI, they didn't go together at all. That B1 inhomogeneity and caused those big large signal voids that you can see here and the standing wave effect. So wasn't used and didn't really work out. But if you've got a brand spanking new scanner with all the recent hardware, and if I think we heard a talk yesterday about the multi-transmit RF coils, that's really going to help a lot, and it's definitely achievable to get 3T fetal imaging now, and it definitely is being produced, although not to a large extent. There's not much literature out there on 3T imaging yet. And that might be because you actually have to modify your sequences a bit. Obviously, 3T is potentially going to give you much more SAR, so you're going to have to modify your sequences to reduce that SAR down to the normal level, and that's going to lengthen your shot time, and you're basically going to lose all the benefits of going to 3T anyway. So while it might be achievable to go to 3T, it definitely isn't better than 1.5 at the moment, or that's what the current opinion is. And most large centres are still using their 1.5 scanners. The future. I don't know what time I'm at. I'm okay. So just quickly, this is where there's lots of research going on at the minute in fetal MRI. DTI imaging, obviously that's going to have great potential, being able to see the progression of the DTI imaging over the gestation of the baby. So that's potentially going to be really interesting. Spectroscopy, functional MRI, both being performed. And cardiac imaging, a lot of papers on cardiac imaging recently. They're attempting to perform cardiac imaging, and they're also now using sort of novel gating techniques so they can actually get some functional information out of their cardiac imaging. So that could be quite interesting as well. And volumetry, more 3D sequences coming along now that we can use. Even though the spatial resolution is still quite low, it's getting better all the time. So eventually we're going to be at the stage where we can use 3D sequences and get really good volumetry through the gestational ages to look at, you know, normal versus abnormal volume sizes. Just like to thank the following and hand over to Michelle, who hopefully is going to show us some very nice case studies and explain a little bit more about where fetal MRI is useful and where it makes a difference.